Um, and we also help healthcare facilities, especially private healthcare facilities, with access to credits, so that they're able to access affordable loans that allow them to do investments, but also to have working capital to finance supplies that they need, for example. So it's really a holistic approach, and everything that we do is supported with thorough research and analytics to really understand the impact of what we're doing, and also continuously improve and evolve our innovations. Our work is really around developing innovative projects and demonstrating at a small scale how they work, but then scale through partnerships through the rightful institutions in the countries that we work with. So that could be with the government, it could be with the national social health insurance system, but it could also be with local banks through the loans, for example, and with local medical associations and private sector associations through safe care and quality improvements. Our main countries of operations are Kenya, Tanzania, Nigeria, and Ghana, where we also have offices. We do work in other countries, but usually with spin-offs of some of these projects that I just mentioned. But in these 4 countries, our holistic market-based approach is taking place. We firmly believe that digital technology is the enabler, or one of the main enablers to making things happen, because you can really leapfrog a lot of activities that are difficult to implement with government systems that sometimes have limited capacity, but also allow you to really empower the individual, which, especially when it comes to lower income groups, these people are often marginalized, and their voice are not always heard in the healthcare system, and it can be difficult to reach them and really make sure that they are pulled in. We're a relatively small organization. We have about between 200 and 220 staff. It always varies a little bit. The majority on the African continent, with a smaller head office in Amsterdam, providing support to everything that we do. Next slide, please. So with Momcare, the problem that we're tackling is this one. In the countries that we work in, and I've used the example here of Kenya and Tanzania, maternal mortality numbers are still dreadful. The numbers are high, especially if you compare it, for example, with the United States or the Netherlands, where I come from myself. And the strange thing about this is that we actually know what we have to do to prevent maternal mortality and really reduce these bad numbers. It's about making sure that women go for 4 A&C visits. It's about skilled A&C visits. It's about checkups for complications. It's about vaccines. And it's been well documented through various Lancet published and other publications what it is we need to do, making sure that the women seek professional healthcare in healthcare facilities. And yet the women often don't show up. They don't show up early enough. They forgo A&C visits. And when they do go to the healthcare facility, very often not all the necessary diagnostic checks or treatment protocols are followed. And the result is that especially women that are high risk have a high risk of also suffering poor health outcomes. Next slide, please. So this is basically what we're looking at. And the interesting thing is that when we think about healthcare provision and the people that we cater for, I think all of us in this call, is that you have very different groups. So you have what we call the low-risk women. In this example, we used Mary as an example, who is an adult woman in a very stable social setting. She's really thinking about spacing her family, but the family is definitely welcome into the environment that she sets in. She has no previous pregnancy complications, so she's relatively low risk. Susan, for example, is younger. She's dropped out of school, and she's not been on every healthcare facility visits that she's been on, already putting her at a medium risk category. And then on the right side, there's Tabitha, which is a 16-year-old teenage pregnant girl living already with HIV, AIDS, and malaria, estranged from her parents, and the risk of her not getting the right healthcare and experience poor health outcomes is very high. Next slide, please. So when you think about what these three women need in terms of getting better healthcare, it's actually what we call the hardware and the software of things. So when it comes to the hardware, you have to make sure that protocols are followed. And as I started my discussion with, we actually know what these protocols are. The maternal child pregnancy journey is very well documented and written, and every doctor, nurse, or midwife should know what to do. There should be an enabling environment, so there should be the right infrastructure, the right medication, quality standards should be met at the facility level to make sure that staffing is there and the right equipment, everything is maintained, and medication is not expired. But there's also what we call the software. This is about behavior and economic conditions, something that you'll probably all recognize in your own work. When it comes to uptake of SRH, or when it comes to uptake of ANC visit, it is about making sure that the patient is actually going to the healthcare facility and understands the medical need of taking up these services, as well as the behavior of healthcare professionals to cater to these women that can be of very different backgrounds and may need a different way of being convinced of why it is important for them. So it's not a one-size-fits-all approach. And also the experience of care, have women been treated well? We know that there's a huge issue with teenagers who are often frowned upon when they go to the healthcare facility, which prevents them from coming because they feel shame, when actually they should be the first that come in more often. So that experience is also a very important aspect in healthcare seeking behavior of the people we try to target. Next slide, please. So what we have done is developed a digital care bundle. And a care bundle is, sometimes people think it's a different way of selling an insurance product, but a care bundle is in principle a set of interventions that, when used together, significantly improve health outcomes. So that means that if you want to make sure that this happens, you need to be centered on the outcome of the patients. Make sure that there is quality support at the healthcare level, that the doctors and nurses know what to do, that the women have access to that care. And for that, in our work, we've used a mobile health wallet, which is a digital system on the phone of the women. It looks a little bit different, similar to M-Pesa. Many of you might be familiar with it. So it's a health wallet that you open when you go to a healthcare facility, and the computer system recognizes that you are at a healthcare provider and allows the healthcare provider to start offering services and also start billing for those services. The money is ring-fenced, so you could not use that same money and go to the shop and buy a coffee or something else. It's really allocated for healthcare funding, and you could put a digital voucher or a digital care bundle in it, like the example I'm going to talk about today. But we also use it, for example, in Kenya to offer NHIF insurance, which is the national insurance system as well. It really creates an empowerment with the women because they go to a healthcare facility and they initiate the healthcare process rather than, which is in a lot of examples the case, that they have to go to the healthcare facility and just hope for the best, that medical professionals are there and that the medication that they are entitled to is actually provided to them. So it's really an empowerment process, putting, in this case, women at the center, but typically the patient at the center. There's also a journey tracking aspect. So this is the whole digitalization that follows when these women go to the healthcare facility, the services that they have received, but it also allows us to reach out to women when they're not the healthcare providers and ask them, for example, what their experience was. But we can also remind them that they have their next ANC appointment, or, for example, of dietary needs that they should be taking care of while being pregnant, or give them advice on the risk of COVID during the pandemic. So it really allows you to be interactive with patients, also when they're not in the healthcare facilities, which is actually the moment when very often you lose people to follow up. Next slide, please. So this is really what it looks like. So it's one platform that connects patients, payers, and healthcare providers, but what it looks like is different for these three different groups. So on the left side, what you see is what the platform does for the healthcare provider. So the healthcare provider uses a smart app or a tablet and can see exactly the women who are registered at their healthcare facility. Hopefully it's clear from this slide, but the women are color-coded. So they immediately signal if somebody is high risk or low risk, so that the healthcare provider is grabbing attention when a woman needs more attention in terms of healthcare. But it also sends reminders to the doctor if maybe last time they forgot to do a test, to repeat that test during the next visit. For the health wallet, for the patients, for the pregnant women, they can actually use a very simple feature phone, like an old Nokia we all used to have. And it sends them reminders, but it also shows them entitlements. So the time that, as a woman, you would go to the healthcare facility and the doctor would say, well, this is not part of your care package, is over. There's transparency and accountability that this is what they're entitled to. And as I mentioned before, they can really start demanding for that entitlement and really be empowered. I think on the payer side, we have dashboards that allow payers to see who the women were that access these services, obviously at that point at an anonymized level. So you could never see that it was Nicole getting access to certain care. Next slide, please. So, but this is basically what a journey tracker looks like. So it's a complicated slide. I don't ask you to read all of it, but it's basically a protocolized digital journey from the very first visit when a woman is established to be pregnant to that second ANC visit. And during all the steps, the doctors in our team have agreed upon a care journey where we say, this is what needs to be done. Blood pressure needs to be checked, HIV test needs to be done. And the moment elements are missing, there is a trigger that is sent to the healthcare professional, and there is a trigger that is sent to the woman, so that together they are, as the journey is still ongoing, reminded on what action needs to take place to make that journey more adherent, which, as I explained at the start of my discussion, is so important to manage risks and minimize poor health outcomes. Next slide, please. This is a little bit of a repetition of what I just mentioned, but again, it really takes the pregnant woman at the startup so that she has clear what is her entitlement. She's the one validating the service, saying, yes, I went to this healthcare facility and this is what I received. She can give her experience score, but also voice complaints. We actually sometimes get that when they've been treated rude or they had another poor experience. The payment is ring-fenced. And then is triggered so that the healthcare facility also gets paid for the services that they get. And the wallet is what we call smart, which means that if there is better quality journeys, it allows for a pay for performance mechanism to reward those healthcare facilities that did quality journeys, especially for high risk women. Next slide, please. So these are just some numbers. We're operational at the moment in Tanzania and Kenya with about 40 facilities in Tanzania. This slide says 19. I think we're already up to 25 facilities in Kenya, where cohorts of women are accessing these services. Obviously, a journey takes 9 months. And what we do with these cohorts is every time we add services to it to understand how we can make these journeys better and more adherent. Next slide, please. Next slide, please. Yeah, thanks. So this is just to show that improvement can be achieved. These are the different cohorts that I've been talking about. So we're already at our 9th cohort times 9 months. So the project have been running for quite a bit now. And we're working with the healthcare facilities with this continuous feedback mechanism of telling the healthcare professionals what to do, rewarding if they do well, but also engaging the women, because if they don't show up and they don't go to the healthcare facility and don't understand why they should be doing this, then obviously the journey doesn't work. So we see that as we go through the cohorts, the number of good journeys are increasing and risk is being managed better, although it's also clear to say that we're not there yet. And we're unfortunately still missing, especially when it comes to teenage pregnancies, which we experience a lot, especially since the lockdowns during COVID. Unfortunately, there's been a surge of teenage pregnancies that tend to show up late for their care journeys. Next slide, please. This is another interesting slide, and again, a little bit complicated, but let me talk you through it. What this shows is that on the left, you see a list of healthcare providers that we work with here in Kenya, and not all healthcare providers are seeing the same profile of women. So on the top is St. Elizabeth Hospital. It's a hospital we work with for many years. It's this amazing place in Western Kenya. And you see that this hospital is seeing a lot of high-risk women. This hospital, it's a faith-based facility. It's in the middle of rural Kenya. There's an amazing matron that is leading this hospital that is very proactively reaching out to what are unfortunately a lot of teenage pregnancies. And you can see that she's able to manage them actually with quite good quality and really uptake also these vulnerable groups. Redeemed, on the other hand, that is on the bottom, is seeing a lot less of these high-risk women, which is not necessarily a bad thing. It doesn't mean that they're not doing a good job, but it does mean when it comes to paying for healthcare services, it's important that the high-risk women will need more care, and that with this digital system, you're actually able to allocate a little bit more financing, recognizing that St. Elizabeth is seeing a lot more complications, and as a result will need to do more care interventions than a hospital that is seeing less patients with high risk. Next slide, please. We can actually rate journeys. So we've grouped them again. This is work in progress, but this is what our medical professionals are looking at the moment, so that weighing the various aspects in the care journey and how important they are to manage risks and improve better health outcomes, they're able to identify journey scores and rate them from 1 star to 5 star. again, in a much simpler way, recognizing healthcare facilities that are doing a good or a bad job. What drives a good or a bad journey, and I could talk about this for hours, which we don't have to today, that time, but a lot of it has to do with the profile of the mother herself, her socioeconomic background, where she comes from, age, being in a stable marriage obviously has a very different outcome from teenage pregnancies, but also having timely use of an ultrasound, and what could be an obvious one, but still the distance to a healthcare facility to be able to access care. Next slide, please. Moving a little bit into the field of this audience, as I was preparing and having the discussion for this session today, I actually asked our data team to look at some of the uptake of family planning methods in the cohorts of women that we're dealing with. Now, there's already one reason what you're going to see is that the uptake is not very high. The main reason for that is that a lot of the women go for their maternal childcare to the bigger healthcare facilities, and family planning is very often delivered in smaller healthcare facilities just around the corner where our program is not running. So it doesn't mean that the women that are not on this slides are not accessing it. It just means that we're not capturing it always all the time. But I do think you will already see some interesting data. But the main point that I want to bring across today is that with a care bundle like this, you could actually monitor and record that, but also proactively reach out to women to engage them more in uptake of these methods. But also be able to monitor how much has been utilized and ultimately also help with the planning of the supply chain as a result, because it will be much more demand driven rather than a push methodology when you don't know what the uptake will be. But some interesting aspects, and this audience will know much more about this than I do, but you see that there's quite some family planning activities within in the healthcare journey. About 15% get some form of family planning. So this is a very generic term. I'll deep dive in the next slides. We see that teenage counseling is there in about 7% of the cases. 5% of the total group received contraceptive, and about 22% of the total group of women received consultation for postpartum family planning after their care journey. We see some injections, IUDs being given. Oral contraceptive uptake is actually quite low. And we have not registered any condoms, but it's probably because they were given but not registered in the system. Because I know a lot of the healthcare facilities we work with actually do have them and distribute them, but because they're free to give, they don't report them. Next slide, please. This is also, I thought, an interesting analysis, and in a way a very hopeful one, at least I felt so, that if you look at the different age groups, actually the teenagers are receiving a lot of consultation and contraceptives. So it does mean that there is proactively a strategy in place at these healthcare facilities to make sure that especially the young girls, don't show up 1 year later with the same aspect again. But also the other age groups are receiving consultation and are receiving contraceptions. But I think the uptake still has a lot of room for growth, and it's actually a very good opportunity to start talking about these things. Next slide, please. One of the things we can also look at is utilization per region. Our project is running right here in Nairobi, which is obviously a bit more of a modern setting, although we do run it in the lower income areas, and in Kisumu County and Kakamega County, which are more rural areas in Western Kenya. And you see that the utilization in Nairobi, so utilization of contraceptive there is about 10%, 10% that we record. And Kisumu and Kakamega is much lower, about 3%. So we see that the uptake in rural areas is very different. And I think related to that, it also comes with a different type of, how do you address these women, because they have a very different social backgrounds and cultural backgrounds. And I think approaching them will probably need a different approach than convincing women here in Nairobi to uptake contraceptives. Next slide, please. Sorry, next slide, please. Oh, do I have it? Oh, yes, sorry. Another analytics that we've done, probably not a surprise for many of you in this call today, but the highest uptake or the distribution of teenage counseling and family planning is in public sector facilities. It's offered there at the moment for free through government run programs. And we do see it's indeed taking place there. At the private healthcare facilities, the teenage counseling seems to be very limited. It's mostly contraceptive and family planning in general, whereas at the faith-based facility, the distribution of contraceptive is a lot lower. Very often, this is something that the faith-based facilities don't do because of their religious backgrounds, but they actually do quite a bit in terms of teenage counseling. This is probably where a lot of the teenagers will go to because it's very often offered for free for this vulnerable group. And this is probably a facility that they feel most comfortable going to in terms of their own setting. So that was a very interesting observation I found. It also shows that in terms of your strategy in addressing and bringing on board healthcare providers to provide this type of services, the approach of doing that will probably need to be different and vary from the different type of healthcare facilities. And digital structures like this can help you provide the insights on how these interventions are working, and if you indeed see a higher uptake of these services in these healthcare facilities. Next slide, please. We also had a look at the quality of the journey score. I showed that to you earlier, how we're able to rate the healthcare facilities from a journey score of 1 star to 5 star. And you do actually see that healthcare facilities that are scoring higher in terms of the quality of the maternal childcare journey, that they are seeing higher uptake in terms of contraceptive use and consultation. So it does seem that as healthcare facilities are really becoming better in care journeys, that this is something that is incorporated. Again, a lot still to be gained. But that's making this part of a journey will actually is more likely to increase the uptake, because it's something that is part of a care process that reaches women at the moment that they are at a healthcare provider receiving care, which will add value to, of course, disseminating this information when they're outside the healthcare facility and not pregnant yet. And then I think the last slide, please move to the next one. So this has just been a little bit thinking for myself, and hopefully to start some of the discussions. I already noticed some questions in the chat. But I think there's opportunities in these care bundles and using digital technologies to integrate sexual reproductive health services into a care package, into a UHC approach that is an opportunity to merge these different activities. And it's very logical that for a long time it was a vertical parallel system, because you wanted to make sure that you reach the women that this was meant for. But I think as technology is evolving, actually by integrating it, you can make sure that at all points when women are receiving healthcare or outside the facility, they are reminded of the importance of the uptake of this important family planning method. But that also allows implementers to see why certain groups maybe are not uptaking it and adopting strategies to change that. For example, by creating more youth-friendly services for teenagers. So just a little thought experiment, and with that, let me end my discussion or my story now, and open the floor for a discussion. Thank you very much.
Thanks, Nicole, and much appreciated that you all took the time to sort of link your broad work with maternal and antenatal care to family planning. There are a number of questions that came through the chat, and so what I would like to do is just to call on the folks who pose their question to come off mute and to feel free to ask directly. If you feel that you can't come off mute, just send me a little note in the chat and I'll read that question for you. So perhaps Nancy, I think your question came in first. Can we start with you?
Can you hear me?
Yes.
This is sort of an overarching question. I think the package is very exciting, and I think it could certainly work in also places such as the US, especially younger teenage populations. So I'm not questioning the overall design, and Kenya is probably one of the few countries where it would work in Africa, but sometimes I think we get so involved in the technology that we forget that the experience lived of most women is that it is pretty useless for them to do antenatal care. And I know everybody gets shocked when I say, well, let's lessen antenatal care, because the quality overall in Africa is so poor that sometimes it actually encourages women to deliver at home. They come for a visit, they get checked, they hear everything's okay, they don't have proper tests, and so they don't deliver in a facility, and then they don't have access to home-based misoprostol, and they hemorrhage, and no one tells them that you can't predict many of those outcomes. I could go on, but I won't. All I'm saying is that until we can guarantee high quality antenatal care, some of these innovations are going to not be very useful for women and not save lives. So maybe programs should focus on directly saving lives at the moment of crisis.
Thank you, Nancy, for that comment. And you're absolutely right. I mean, we're very often sending the women to a place where they're worse off than where they came from. And I think there have been some number of World Bank studies, especially in India, where they gave women vouchers to deliver in a hospital, and maternal mortality went up instead of down. So the evidence supports that. I think because of the sort of the length of the presentation, I had to cut corners here and there. And I think probably one of the corners I cut too much is the very much part and parcel of this program is this continuous feedback to the healthcare providers. So the application was actually co-development with the doctors in the healthcare facilities, protocolized, and they continuously get triggered. So as a woman is entering into the healthcare facility, the application on the doctor side already says, this is Nicole, she's a high-risk woman because she has hypertension and HIV. You forgot to do the HIV test last time, or things like that. So it already triggers reminders. It's not a decision support tool, but it's a reminder telling a doctor that, look, according to the protocol, you've missed certain things, or the patient has certain things, and you should be doing this. In addition to the digital system, all of our healthcare providers have mortality and morbidity meetings, so basically clinical audits, looking at the data together and discussing what should have been done better. And for a lot of the medical professionals, this was actually eye-opening, because all of a sudden they could see what they had been doing and what they had been doing wrong. We do that in a very safe environment, and we've created hub and spokes so that also larger hospitals can, and more experienced people can guide smaller healthcare facilities to really create sustainability. So to really work on a continuously quality improvement. And as I hopefully been able to see, we do see journey score improve. By no means I want to say that this is a magic bullet, because some of the healthcare facilities we had to let go because they didn't want to improve and they didn't want to see what they were doing wrong. I do think part of the empowerment process of the women is also to help them create more of a voice, because I think the tolerance for poor healthcare in Africa is also terrible. And we should educate patients a little bit more to speak up and demand what they're entitled to. But this is a long journey. I'm not saying we have a magic bullet yet, but hopefully I've been able to convince you that some of the technology can be supporting, but are definitely not the means to an end.
Thanks, Nicole. Our next question comes from Kabir. So Kabir, could I have you come off mute and introduce yourself and your question? Kabir? I don't know if Kabir's still there, but I can ask the question for Kabir, which he's asked. He has two very basic questions. Are these platforms in local languages or in English? And who provides the phones? And has there been any problems with connectivity?
Yeah, great questions. So the platform itself on the healthcare professional side is in English. Which most of the healthcare professionals speak in Tanzania and read in Tanzania and Kenya. Tanzania, we have a little bit more issues than Kenya. The communication to the women at the moment is available in English and Kiswahili, which is a very common spoken language, obviously, in this part. The phones, the women themselves use their own feature phones, which 90% of Africans have at the moment. Sometimes the women don't have a phone, but they will have a SIM card, and then they share a phone. So we've been able to reach most groups, recognizing that the very poorest of the poor are unlikely to have a phone. But we're targeting the group just above that to start with. Problems with connectivity sometimes, so we're also working on an offline version at the moment. In Kenya, we didn't have a lot of problems, but in Tanzania, connectivity can be an issue, so it's something we're trying to address.
Thanks, Nicole. Our next question comes from Catherine. Catherine, would you mind coming off mute, introducing yourself and your question?
Hi, thanks very much for the presentation. Really enjoyed it. And we've chatted before. My name is Catherine Taylor, and I work for Mothers. So my question is, I've been around long enough that in the 90s, we were trying to identify women at high risk. And, and actually, we, at that point in time, it was all about traditional birth attendance and antenatal care. And with the work of of Deborah Main and others, it became very clear that the women who were dying were low risk, because while there was efforts to improve care in high risk women, the low risk women were not really were not really cared for in the same way, and when they did get complications, they were missed. And as one of the previous callers mentioned, with pregnancy and childbirth, low risk women can get complications just as as it moves forward. So I've been hearing this a lot lately about identifying high risk women and making sure they get care, and it's just a little worrying to me. I don't want to see sort of us going back to the situation where we were getting a lot of women who were low risk were not being identified when they got complications. So just wanted to get your thoughts on that.
Yeah, no, Catherine, and great to connect again. I think you're very right. This is, in fact, there can be so much attention in a lot of, especially donor-supported projects on getting those complicated cases in, right? You see the same thing, in fact, happening now with COVID. We're talking about oxygen when the majority of the disaster is happening at the primary healthcare level. So you're absolutely right. And I think this is very much about identifying the right journey for the right risk profile. So not necessarily paying more attention to the risk groups, but recognizing when certain steps need to take place. But also what we're doing very much is what happens if you introduce additional services. WHO, for example, is recommending 8 ANC's visits at the moment, which is next to impossible for the women that we're accessing. Is this really necessary? Or is it more a matter of doing the right test so that indeed also low risk women are getting the right care, or that any complications may be missed because they haven't been receiving the right attention in the first place? So your comments are very well noted, and I think it's a discussion we continuously need to have as medical professionals, looking at this data and saying, are we really doing the right things with the right groups? Or actually, are we, putting too much attention on one group and causing bad side effects to the other groups? So your comments are very well noted and very valid, and I think something we need to consider moving forward.
Thank you both. So then this next question, and forgive me if I mispronounce, so I look forward to hearing the correct pronunciation, is Aitino?
Yes, good evening. And thank you, Nicole, for a great presentation. I think this is a great initiative. The name is Atieno.
Atieno.
So you are very close. Now, I think the initiative and the Momcare app probably is to work towards having a great maternal journey and hopefully great birthing experience. So my question was asking whether in this system, do you get the experiences of the mother, and in terms of the birthing experience, and what outcomes they get at the end of the maternal journey? And then secondly is, are these then correlated to the maternal, to the care journey? That was the second.
Great question to Achena. Thank you for that. Yes, so the birthing experience and the outcomes are part of the journey score. They are weighed into, so a bad outcome does weigh in. Unfortunately, sometimes you can have a good journey, but still a bad outcome. But we try to reduce that as much as possible. But also how the woman experienced it. So they get text messages that they can then reply. But we also, at the end of the journey, we have a follow-up phone call. I find the women open up a little bit more during these phone calls. They're always a little bit hesitant to report bad experience when you talk to them one-on-one. they will have sometimes really terrible stories about being slapped or abused, during a journey. Unfortunately, those are very rare incidents, but we've had feedback where the whole team was practically crying when they heard it. It's also part of the feedback sessions. So when we sit with the doctors and the healthcare professionals at the healthcare facilities, this feedback, obviously anonymized, is returned to them and is part of their improvement activities. And obviously, if there's a healthcare facility doing dreadful things, we will remove them from the program, but fortunately that has not been the case.
Great. And then the next question that we have is from, let me see here.
I think it's the data privacy.
Yes, it's the data privacy. It's Arinze. Please feel free to come off mute and introduce yourself and your organization and your question.
Hi, my name is Arinze. I work with Concept Foundation. So a lot of times when these kinds of interventions, which I think is really timely, when it has to do with digital tools to improve health outcomes, as is the case with Momcare. One question that comes up is the use of data and data privacy, data storage. And I know in many parts of the world, in Europe, for example, there are clear-cut guidelines and laws that govern the collection, the use and storage of data. And so I was wondering how the data is collected, but more so how it's stored, and if there are any issues regarding the privacy, especially of the patients. Yes, and how you've been able to go around this in the countries of solution.
Great question, Arinze. Thank you for that, and a very important topic. I'm not an IT person, so I'll try to answer your question within my available knowledge. But you're right, currently the most mature law in terms of data privacy and data protection is what we call the GDPR law in Europe. Being originally an organization from the Netherlands and recognizing that this is the gold standard at the moment when it comes to data protection, we have decided to comply to GDPR, which means that actually everything, how we implement, how we collect the data, it means the women have to give informed consent. There are certain rules and regulation on how this data is stored and protected in the Azure cloud, which again, not being a technical person, I won't be able to explain to you, but there's about 4 people in our office that know how all of this works. And also as an organization, we are audited to make sure that compliance indeed takes place. It's also part of GDPR, for example, is that people have the right to be forgotten, so that if any of the women or the organizations decide to, step out, then we have to remove that data. And the very basis of GDPR is that the ownership of the data is always with the patient, and we think that very fundamental right is extremely important. We help analyze it, we'll help give it feedback, but we definitely do not own the data or would it put it to commercial activities in any way at all. It's really meant to empower the individual and create better healthcare journeys. What you see right now is that the good thing is that a lot of African countries have started to think about it. At the moment, actually, Kenya is working on a new e-health bill. And fortunately, you're seeing that they're taking a lot of examples from GDPR so that the regulation will be stricter. And it's something that we highly encourage and also try to help governments with in putting that in place.
So we have just a couple of more minutes and I don't see any more other questions in the chat. Does anyone else want to come off mute and ask any final questions to Nicole? I think there's a
Well,
rule.
if not, anyone can always call me. I think actually the next slide I had added my name and my contact in case you want to reach out to me at any point. So please, it's one of our favorite topics to talk about. Oh, here's my my email address, and showing off that we also won the Commonwealth Digital Health Awards with our product. And you see actually a picture here on the team working with the application. So please feel free to reach out to me at any time, and also open for questions, but also potential collaborations.
Great. Thank you so much, Nicole, for a thoughtful presentation and for everyone's great questions. We appreciate you being with us today.
Thank you very much.
Great. Take care, everyone.
Thanks. Thanks, Tanvi, for inviting me.
Absolutely.
Bye.
Bye-bye. Bye. Take care.